Yeah, so this is very early data from an ongoing clinical trial where the vascular targeted therapy, where there's a protoporphyrin derivative given intravenously, and then a near-infrared light laser used to activate it and target the tumors. So entry criteria are very similar to the trial that we did with Urogen using Jelmyto, where it's low-grade disease. I think the criteria were up to 15 millimeters. They treated both renal pelvis and ureter. I think the ureter tumors could be a little larger. So they basically reported on 12 patients. So very early data. They had a complete response rate of about 2/3, I think. They don't really have durability data, right? So it's sort of an initial, I would call it safety, kind of a look at efficacy, and I would say, so far so good. I think we're at Baylor, we're in the process of activating the trial. I think that this whole approach to nephron sparing in low-grade disease is something that's really important for urologists to understand and to incorporate into their treatment. So we have an approved agent, Jelmyto, and I think this is an opportunity to develop, additional therapeutic options for these patients. Yeah, kind of a fancy title. The ROBUUST registry, we had 3 abstracts in the session, and there was also a multi-center study from a couple of other sites kind of looking at similar questions. So just as a matter of principle, I think that these registries are important, but they're essentially hypothesis generating. It's low-level evidence, it's retrospective data collection, very hard to control for a number of different biases in terms of who we offer neoadjuvant to, who we offer adjuvant to. So having said that, I think that a very strong message that I conveyed during the session was that as urologists, we should be doing multidisciplinary team evaluation and tumor boards for patients who have high-grade disease and a suspicion for invasion. That could be on cross-sectional imaging, it could be on size, it could be on morphology, and absolutely patients who have, clinical node positive disease, and have discussions about neoadjuvant chemotherapy. Axel Heidenreich, who's in Cologne, made the point that, and in Germany, the urologists many of them are credentialed to do chemotherapy, and so you can actually give cisplatin-based chemotherapy in Axel's hands down to an EGFR of 40 using split dose. With 2 kidneys in place and presumably adequate renal function, that's an opportunity to do neoadjuvant. But we also have level 1 evidence for adjuvant chemotherapy from the POUT trial in patients who did not get neoadjuvant. And we also have data from a phase 3 trial on adjuvant nivolumab from Checkmate 274. So we've got more tools. And as urologists, we just shouldn't run off and do surgery in these patients without really a robust discussion about integrating perioperative therapy. The level 1 evidence actually exists in the adjuvant setting from POUT and Checkmate 274. Now, we've got 2 phase 2 trials that have been published. One is from Memorial, the other is from ECOG, one of the cooperative groups, where neoadjuvant chemotherapy plus surgery in all patients. So the other sort of message was that, or is that, clinical trials are the way to do this because you have uniform entry criteria. And I appreciate that not every place can do a clinical trial or enroll in a clinical trial. And for those folks, sit down with the multidisciplinary team and establish criteria for identifying the patients who are good candidates for neoadjuvant chemotherapy and do that collaboratively. And I think move away from these retrospective, cohort studies to prospective data collection, develop these workflows. So, I think what's happening more in academic centers where we have done this for lower urinary tract disease, where it's just part of our workflow. Patient comes in, yeah, we want you to see the medical oncologist, and and then we do this as a team. I think we should be doing the same thing for high-grade upper tract disease. Well, I mean, yesterday there were two really important clinical trials presented. They're sort of near complete data, one on TAR-200, which is the pretzel and intravesical gemcitabine and BCG unresponsive disease, and the other was from CG Oncology, the replication competent adenovirus with GM-CSF, also intravesical. They both showed sort of in the range of 70-75% complete response in this difficult to treat patient population with CIS. That was exciting, and I'll do a little shout out for what I presented. Was secondary endpoints in the node dissection trial that we did in SWOG and the NCTN, which showed no difference in DFS or OS, extended versus standard, and I presented a number of sort of interesting secondary endpoints. The other take-home message from that trial is that the patients who had the extended node dissection had a higher incidence of grade 3 through 5 AEs, higher mortality. So it's another reason to sort of back off from doing extended node dissections, because it's risk without benefit. So.